Well, our next topic is related to stroke reduction in atrial fibrillation. And to put that in perspective, as we talk to our patients about atrial fibrillation and the risks associated with it, there's nothing they fear more than stroke. It's the most atrial fibrillation is the most common sustained cardiac arrhythmia. In the United States, it affects over 2 million patients. And while it occurs more in the elderly, it's over a broad range of ages. And the prevalence is expected to increase 2.5-fold by 2050. The lifetime risk of developing atrial fibrillation is roughly 1 in 4 for men and women. So a lot of you either have atrial fibrillation or will get it. Now, the prevalence of atrial fibrillation is a little bit higher in men, but it affects both pretty closely. And as you can see, the incidence increases with age. In the kind of work that I do, I see a lot of patients who are in their 30s or 40s or 50s with atrial fibrillation, but certainly more commonly it's seen at the age of 60 and on up. The projected increase in atrial fibrillation is illustrated here, and I think there are a number of reasons for that. One is that the population is living older. The other is that we're helping people with significant underlying lung or heart disease live longer, and these are patients who are more prone to developing atrial fibrillation. It has a big impact on our patients. It does increase mortality, and this is true for people who are on the younger side as well as those who are older. This compares men and women who have atrial fibrillation, shown in the upper lines, compared to those who don't, and you can see that the mortality is greater for both age groups. Now, the problem is that atrial fibrillation strokes are twice as likely fatal than non-AF strokes, and the AF-related stroke recurrence rate is twice as high as non-AF strokes. And that's why these scores to assess risk, such as the CHAD score, or as I'll show you shortly, the TRADS-2 VAS score, have been developed to try to better assess what that risk is. Most countries have now switched over to the TRADS-2 VAS score. The factors that are involved with this are shown in the figure. The differences are that older patients get 2 points, and female gender is associated with a point, as well as vascular disease and other factors. In fact, I read recently that the C in VASC originally was for creatinine, related to chronic kidney disease, and for some reason it didn't quite make it into there, but renal disease is a risk factor for stroke. This shows the annual stroke risk as a function of the VAS score, and just to kind of make it easy to remember, if you have a score of 1, it's about 1%, 2 is about 2%, 3 is about 3%, 4 is about 4%, and then it increases from there a little more steeply. So if you're in the clinic and talking to patients, if you don't remember exactly what the number is, you can kind of bear that in mind, and it's a way of giving people a rough estimate of what their stroke rate is. And you don't necessarily have to remember the exact number because it's probably not that accurate anyway. Now, the problem we have in trying to prevent stroke is that we all recognize that warfarin has a narrow therapeutic window in which if the INR is not in the range of 2 to 3, if it's below that, the stroke risk goes up considerably, and while there are bleeds in the therapeutic window, the risk increases as that number increases. This is the incidence of bleeding in the Framingham study, and you can see that in patients who have atrial fibrillation, the risk is substantial over time, and it increases some in patients who are anticoagulated. And it's for that reason that groups have tried to develop bleeding risk scores. And what you can choose which one you particularly like to use, but they use a number of factors that I'm sure each of us weighs in the back of our minds when we see patients, and this is simply a way of trying to quantify that. And if, as an example, you take the Hasbled score, you can see here that you get 1 or 2 points for these various factors, which take into consider hypertension, you get a point either for renal problems or a point for liver function problems, stroke, bleeding history, or predisposition to this. And if you add this up, you can reach a score as high as 9. Now the problem is the people with the highest bleeding scores are also the ones with the highest stroke risk scores. So the people who most need to be treated to prevent stroke tend also to be the people most prone to bleeding. And that puts us into a difficult situation. One of the other factors that is difficult for us is the time in the therapeutic range for patients on warfarin. In this study that was comparing warfarin to the combination of clopidogrel and aspirin, on the left-hand panel you see that the time in the therapeutic range was less than 65%. And there's not a big difference in outcomes in these patients. In the right-hand panel, you see that warfarin was much more effective, but notice also that the time in the therapeutic range was greater than 65%. And as you'll see in a number of clinical trials that were performed, and these were patients who were followed very carefully, many of them did not have a therapeutic range consistently, and an average, it usually ends up being about 65%. So another thing that I sometimes see is physicians who want to treat people with aspirin and clopidogrel, not because of all the issues that were discussed yesterday with stents and other complicating factors. They just think that somehow those drug combinations are safer. Well, the reality is that the strokes per year are lower with warfarin compared to aspirin and clopidogrel. Disabling strokes and fatal strokes are lower. Major bleeds actually aren't significantly different. So if you put people on this combination of antiplatelet drugs thinking that the bleeding risk is lower than warfarin, it really isn't. And if you look at the ratio of strokes per major bleed per year, it's better to be on warfarin. So if there's a reason to put people on dual platelet anticoagulation, that's one thing, but to use it as a substitute for warfarin is probably not a valid line of reasoning. The newer drugs provide some options for us. They're illustrated here both as the 10A inhibitors and the direct thrombin inhibitor, dabigatran. These are drugs that are given either once or twice a day. The half-life, interestingly enough, even though rivaroxaban is only given once a day, the half-life isn't different. And when I tried to pin the company down on that, they're a little evasive. I speculate, and I have to emphasize this as speculation, I may be wrong. I have a hunch that they chose a bigger dose to give it once a day as opposed to giving a smaller dose twice a day. That's just my guess, because I've never gotten a straight answer out of that. But at any rate, it does work. Dabigatran is differentiated, among other things, by the greater dependence on renal metabolism, and that's a consideration in selecting therapy. And I also think that the incidence of side effects such as gastrointestinal side effects is higher with dabigatran. Now, these are the randomized clinical controls showing the kinds of patients that were in these studies, large numbers of patients. The mean CHAD scores varying from about 2.1 to 3.5. You'll notice the time in the therapeutic range for the warfarin limb ranging from 55 to 68%, despite all the effort that must have been made to keep them in the right range. It just isn't that easy to do. If we look at the results of this, and let's focus on stroke and embolism, you can see that the drug that was being tested always came out looking a little bit better than warfarin. The relative risk reductions range from about 21% to 37%. Now, if you're a statistician and you're trying to make a point, you'll say, well, it reduced the risk of stroke by 37%. But now consider yourself sitting across the table from a patient who doesn't have much money, and I'm not sure how it is in Colombia, but in the United States, some insurance companies pay for the newer drugs and some of them don't. So it may be completely covered, or it might be as much as $400 a month. So if they don't have a lot of money and they're worried about their risk of stroke, another way of thinking about it is what's the absolute difference in stroke reduction. And there you see that this is actually a very small number. Now, it may have significance when it's applied to large populations, but at least the way I interpret the data, if this is a patient with limited resources and they can afford Coumadin better than the newer drugs, there's nothing wrong with giving them Coumadin. And you shouldn't make them worry or feel bad that they can't afford to take the new drug, because the differences are small. The same thing is true for major bleeding and hemorrhagic stroke. I think there's no question that, at least for hemorrhagic stroke, the newer drugs have a lower incidence of that. For major bleeding, it's been better for apixaban and endoxaban, but not for rivaroxaban or dabigatran. And so when you look at these various measures, this is a analysis of multiple studies in which it showed that if you look at stroke or embolic events, the newer drugs are favorable relative to warfarin. Same thing for is for efficacy and safety outcomes. Same thing is true for major bleeding for NOACs versus warfarin. So although not all of them necessarily do that, I think the other thing sometimes patients will say is apixaban a lower bleeding risk than, say, rivaroxaban? Well, maybe, but maybe not. They've never really been compared directly together. So the fact that it showed a lower incidence compared to warfarin in one study, but the other drug didn't show a lower incidence, doesn't necessarily mean to me that you can be sure that there's a true difference between the drugs in bleeding risk. Then you have to consider the dose selection for patients with, they're indicated for non-valvular atrial fibrillation, and that does raise the question is, what do you mean by non-valvular? And that definition has been discussed in the literature. Valvular disease usually refers to mitral disease, and so they're indicated for people who don't have mitral stenosis or mechanical valves. Beyond that, the definition gets a little bit confusing. But you do have to change or adjust the dose according to whether the patients have moderate or more severe renal dysfunction. And when you look at the guidelines, what it emphasizes is that warfarin's recommended for mechanical valves. Oral anticoagulants for non-valvular AF is recommended definitively for a CHA2DS2-VASc score greater than 2. And no matter what the CHA2DS2-VASc score, if you had a TIA or stroke, would be 2, I would always anticoagulate those patients. CHA2DS2-VASc score of 0 doesn't require anticoagulation, and for 1, it's optional. And I think that's a discussion you can have with the patients depending on your perception of their risks and what their ability is to comply with an anticoagulant regimen. Because if they don't have the money to go get the tests drawn, or they don't have a place where they can reliably get the warfarin monitored, or they can't afford the NOAC, then there's not much point in putting them on a drug that they're not going to take anyway. Warfarin remains the drug of choice for patients with end-stage renal disease. Dabigatran or rivaroxaban are not recommended for patients with atrial fibrillation and end-stage chronic kidney disease or hemodialysis. Now, following cardiovascular revascularization, this was a discussion that was held yesterday. It was a very comprehensive, elegant presentation of this. It seems reasonable to use clopidogrel without oral anticoagulants, with oral anticoagulants, but without aspirin. And as you may recall from the study that was presented yesterday, if you add aspirin to clopidogrel and an oral anticoagulant, you really don't reduce stroke risk, you just increase bleeding problems. Dabigatran should not be used in patients with mechanical valves, and the restoration of sinus rhythm does not eliminate the need for anticoagulation. Now, we didn't get into this in the prior discussion about patients following ablation, but even if you think they've had a successful ablation, the other thing you have to take in mind is, what is their atrial function like? Because I've seen patients where they had a very dilated left atrium, it wasn't moving well, they were in a normal rhythm, nobody ever documented that they had atrial fibrillation, and they still had a stroke. Probably the reason for that is there wasn't much flow through the appendage and they formed a thrombus and eventually broke free. So I think you have to be careful in patients who have big dilated atria, even if you can't document that they have atrial fibrillation. Now, there are some differences between the American and European guidelines. The European guidelines place a stronger emphasis on bleeding scores to be used to adjust the dose of anticoagulation, so you might choose a lower dose in patients who had a high-risk score. Reasonable. The data for that is somewhat arguable, but I think it makes sense. And the Europeans guidelines have a greater preference for the new oral anticoagulants as opposed to warfarin. Now, there are some patients in whom anticoagulation may not be a good option. And so now I'm going to talk a bit about the atrial appendage occlusion device. In the United States, there's only one approved by the FDA, and so that's what I'm going to focus on. And that's the Watchman device. You can see here that it has sort of an umbrella shape. It's introduced through a transeptal puncture, positioned in the left atrial appendage, and then there's a mechanism by which the deployment is released, and the device is stayed anchored in the appendage, and over time there is an ingrowth of tissue that covers up the device and should make it so that there's no thrombus that will form on it. But during the first 6 weeks or so that it takes that ingrowth of tissue to occur, there's some uncertainty, some evidence that probably it's better to anticoagulate the patients, and that's why most of these patients are treated with warfarin. This is an echo image showing the Watchman device in the left atrial appendage. And this shows the event-free primary endpoint of stroke, embolization, or cardiovascular death in patients who had the control, which was warfarin, versus the device. There were no significant differences in this endpoint. This shows the co-primary efficacy endpoints, in which if you look at the Watchman group, which was 1.9% as opposed to the control group, there may be a slighter greater risk of ischemic stroke. And bear in mind that the Watchman was never compared to the newer oral anticoagulants. But hemorrhagic stroke is lower in patients here as opposed to warfarin. Death from cardiovascular disease was lower, and systemic embolization was comparable. So in comparing the outcomes of the trials, the implant success, these were 3 trials from left to right, reflected greater experience and time. The implant success increased as people got more experience. The incidence of pericardial effusions decreased, and device embolization has remained low, though it still is occurring. And I think what's happening in the United States now that this has been approved and new labs are picking it up, there's a registry that's been developed by the American College of Cardiology that will monitor these events, but we may see a bump in it as people gain experience and are going through that learning curve. This is a meta-analysis looking at stroke rates from reported studies on the percutaneous left atrial occlusion device. Expected rates shown in that one column in the range of 5.5% to 6%, and the observed stroke rates being lower than that. The antithrombotic protocols, I think, are still in evolution. Right now, what we're doing is putting patients on warfarin for 6 weeks following these procedures. There's been some reluctance to use the newer anticoagulants. The line of reasoning, I suppose, is that if they're not good for mechanical valves, are we sure that they're good for this? And the answer is we really don't know. Is it feasible just to use dual antiplatelet therapy? Well, it may work, but my understanding is that there has been some concern about a higher incidence of stroke if that approach is taken. So I think there are things like this that will take time to work out. So in conclusion, atrial fibrillation is a major cause of stroke that can be avoided to a large extent by guideline-based therapy. The newer oral anticoagulants provide an alternative for patients without mechanical valves or with end-stage renal disease. And the left atrial appendage device is new, but it seems to be an effective alternative for patients at risk for bleeding. And I've been looking at a paper submitted for publication that will be accepted and published, showing that over time, it may be more cost effective than warfarin or the newer oral anticoagulants. So time will tell on that, but that's where we are today. Thank you.